Dr. Kym.
Hi, everyone, and welcome to our very first edition of Ask Kym. I get asked all the time how I got into the peripheral artery disease space and starting the way to my heart, which is now doing business as the Global PAD Association. We work with people who suffer from a disease more prevalent and deadlier than most cancers combined. It's called peripheral artery disease, or PAD, and it's blocked arteries mainly in the legs. Left untreated, you could be at risk of heart attack, stroke, and even amputation. I discovered this disease when I was covering a story about a new device. It was a laser device that doctors had told me during a radio show I hosted called Kym McNicholas on Innovation. It was a top technology show in Silicon Valley that was syndicated in 40 markets. And I interviewed these doctors about this, just what was on their mind in terms of new innovation, what they were most excited about. And they said there was this new laser technology that they ultimately felt would unblock 100% blockages in the heart. But the very first leg of the journey, pun intended, were the legs. And it turns out that I knew the founder. I was the founder's secretary back when I was in college for a summer. And I ended up asking him, do you mind if I follow your journey from the very beginning of your FDA clearance process, clear through global commercialization? And he said, sure. So I ended up starting in 2016, traveling the world, nearly a dozen countries, more than 30 states, watching hundreds of doctors perform thousands of hours of procedures in which they treated blocked arteries in both the legs and the heart. And I learned that different doctors have different approaches, different tools, different techniques, different philosophies, and that would equal different outcomes. And learning all of this, I started bringing the information to some of the social media groups. And I discovered that most people didn't know the information that I was providing. And if you go to Dr. Google, it's not there either. And so I decided that it was time to formalize my process of bringing this information to everyone. And that's when the Way to My Heart was formed. I skipped a few steps in there because it could get into a really long story. But now that I'm thinking about it, we might want to go into the real catalyst for, um, not just providing the information to people through social media and through stories that I was sharing online, and even through a website, mydabralaserstory.com. It is still alive and well online. If you want to see my entire journey and what I learned, that's a really good place to go. The technology is no longer in play. The company disbanded at one point due to troubles with their board of directors. And so that makes me really sad that this amazing game changing technology was pulled from the market when the company went down. But you know what? That happens. But needless to say, I'm glad I had the opportunity to go along that journey and learn everything that I did. And the catalyst for moving from a place where I was just casually um, bringing the information that I was learning to people. Um, my dad was on the verge of a heart attack, and the doctor, urgent care, brushed off his symptoms. He said, "Oh, I think I have heartburn," and he was leading the doctor on to really think that he needed some Prilosec. I said, "You know what, doctor? He is 78 years old. I think it's about time that we checked his heart because heart disease runs in his family." And she said to me, "No, he's not at risk for heart attack because his cholesterol levels are normal." And I had to politely and kindly educate her on the fact that more than 40% of people who suffer a heart attack have normal cholesterol in a basic lipid panel. And it's not until you perform an advanced lipid panel that you discover that the quality of the LDL, or so-called bad cholesterol, was really off. He had more of the small, dense LDL particles that when they become oxidized by the trans fats and the free radicals, that they can eke into damaged areas of the arteries and push walls out, and the arteries can harden. And he had a lot of those ultimately when we um, did further exploration. But in the meantime, she said she was not going to do any sort of further testing, that she was 100% certain that his symptoms were that of heartburn. And I said, no, I think we need to get testing. And we went back and forth for a few minutes until I said, you know what? I have a credit card that says there's an ECG in his future. And she said, okay, if you're going to pay for it, I don't have to worry about putting in a diagnosis code um, for um, for that test, and we'll just go ahead and do it. And lo and behold, there was an abnormality. And fast forward, I ended up getting him a nuclear stress test, and it turns out he did have several significant narrowings in his heart. And I remember when I was away, and my dad called to tell me he had the results of this nuclear stress test, and he was excited because he had the results. He knew there was a narrowing, and guess what? There was a cancellation the next day for an angiogram where the doctor would go in and do the diagnostic, pump in the contrast fluid, see which vessels light up the most, and then they would treat him right then and there. And he was so excited about it. And I said, but Dad, who's the doctor? What exactly are they going to do? And he says, well, I don't know. I mean, he's a doctor. He should know what to do. I mean, why would the hospital hire a doctor who didn't have the skills? And I said, well, Dad, I have experience from traveling the world and watching hundreds of doctors, that just because they have the title doesn't mean they have the right skill set for you. Doctors finish at the top of the class and the bottom of the class and still get the title and graduate just like everybody else with every other degree. So I convinced him to take a step back and allow the doctor to call me and have a conversation. So his cardiologist calls me and he says, Kym, we got to get him in. We got to have this test. It's no big deal. I know the interventional cardiologist. He does a lot of my patients. And I said, but what is he going to do? He says, oh, I don't know. I just trust him. And I said, well, I don't. I want a CT scan prior to this. And I want to have a more productive and satisfying conversation about plan A, plan B, and plan C, even a plan D, right? And he says, Kym, no, I mean, we're going to have to do this angiogram anyway. So why delay what's inevitable? Let's just get them on the table. We got the cancellation. We'll just get this done. Just trust me. And I said, no, I want that CT scan. He said, well, the imaging isn't really going to be that good anyway. It's just a waste of time. And I said, well, doctor, what about a 256 slice CT scan? Silence. And he said, oh, yeah, 3D modeling of the heart. Yeah, that's really good. We just got one of those 6 months ago. I said, I know. Let's make use of it. I said, you know what to tell the insurance company to get that approved, don't you? And he said, yes. And that's always an important question. Doctors know what they need to tell the insurance company to get something that they know that you need and what's best for you. And ultimately, what was interesting is that he agreed that it was a great idea. So lo and behold, we got the 256 slice CT scan. The interventional cardiologist was even so interested in seeing the results and going over them with us, because it was such a new technology to the hospital, that we had an amazing 2-hour consult with my dad, my mom, the interventional cardiologist, and the cardiologist, and even a PA came in because they were so interested. And we had a great discussion about all of the different areas, and they pointed out where the significant narrowings were. And what we started at was he was planning to go in with 5 stents and roto-root everything. And ultimately, he ended up with just getting 1 stent at the time. And then we put him on a serious lifestyle modification program. And so throughout that whole experience, my dad still credits me for saving his life. I decided that I needed to do more than just provide information to other people. And the area in which I had most experience was peripheral artery disease. And so that's actually when The Way to My Heart was born in 2019 on September 4th, my birthday. Coincidentally, it came to be. And I decided to provide not just education, but high touch advocacy, preparing people for their appointments, advocating for them during their appointments, helping to ask the questions that aren't being asked, and helping to translate that information more effectively from the doctor to the patient, and then following up with people after their appointments to ensure that they had a comprehensive or have a comprehensive understanding of the diagnosis, of the treatment options. And then we also work on getting the second opinion, because it's really important before any procedure or even with just a diagnosis that you do get a second opinion. And any doctor that does not want you to get a second opinion, or bulks at it, or makes you feel bad about it, or, makes you feel guilty because you want to get one, or that you don't trust them, they're not a doctor that you want to be with anyway, because the greatest doctors actually love when you go and get a second opinion. And in fact, they want you to come back and share with them what the other doctor had said, because the greatest doctors love to learn from one another. And that's why I love going to conferences such as what I'm attending next week with the new Cardiovascular Horizons Conference in New Orleans, NCVH. I go to conferences all over the world. And what I love is the doctors sharing their knowledge with other doctors, and the doctors that are there asking questions and wanting to learn more, wanting to grow, wanting to do better for every single one of you every day. So that's my story, and I'd love to open it up to questions. I see quite a few people have joined in. Go ahead and either raise your hand or just speak up, and we'll I'm in the hot seat and I am facing the firing squad. So go ahead. I think Alan was dying to get started, and Alan, you just need to unmute.
There we go. Hey, Kym. Well,
I
it's a
knew you
three
were
part
just sitting there trying to unmute.
it's a three-part question, and
Uh-oh.
it's about the future, what you
Okay.
see for PAD treatment. Um, Over the next, say, 5 years, where do you see the technology going with what you're seeing in innovations now? Where also do you see the number of doctors getting more into this? Are there fellowships available to teach below knee uh, intervention? And also, do you see the vascular community becoming more widely accepted as far as this type of, or accepting this type of treatment?
I love that you are so knowledgeable about the big debate out there and the controversy over treating below the knee. And it's something that I know that you have intimate experience with several doctors, some telling you that they can treat below the knee, others telling you they can't. And ultimately, the ones that can actually helping to preserve your leg even longer. And, it's really important that the doctors do come into agreement as to what the standard should be for treating peripheral artery disease patients overall, not just above the knee, but also below the knee. I cut my teeth on peripheral artery disease treatments in one of the most advanced areas of the world, and that was in Italy with Dr. Marco Monzi and Dr. Mariano Polania. And that was in 2016 and 2017. And I had made, over the course of the time that I've been doing this, I literally have been to Italy nearly a dozen times to watch these doctors. And what impressed me the most was the fact that they could take these wires and balloons into the most fragile small vessels, clear into what's called the pedal plantar loop in the foot, small artery loop in the foot that feeds those toes. And it was interesting, with so much experience and so much time over the years spent there, that when I would come back to the US and I would watch some doctors, and, and they would quit when they would get to the knee or just beyond the knee, the popliteal artery in the knee. They would get just through the popliteal and then they would leave the arteries below. And I would ask, I don't understand. You still have flow trickling to the feet. Don't you think that you should just kiss those tibials with a little balloon? Oh no, we don't do that. That'll just increase the risk of amputation. And I would say, but they do that all the time in Italy. And Dr. Marco Monzi and Dr. Mariano Polina, they have some of the highest success rates in limb salvage, more than 85%, with the lowest readmission rates in the entire region. So if they can do it, why are you not doing it here? And I started feeling like they were simply, some of these doctors were just arguing for their own limitations. Either they didn't have success at it, because it does take some special skill and a lot of patience to go below the knee into those smaller vessels, and particularly into the foot. Not just anyone could do it. It made me think that those doctors that weren't having success and saying that treating below the knee arteries was leading to an increase in amputations is that they just didn't know how to do it well. And they weren't, putting their egos aside and saying to some of the pioneers in this space, hey, you know what? Teach me. I want to learn. I want to grow. And so they just stopped doing it, and they started putting out these studies. And that's why I take some studies with a grain of salt, because you have to look at who's doing it, what's the agenda, what's the skill set of the doctors that are in this study. And you could be the most fantastic speaker and world renowned with a great title at a large facility, well known, and not have those practical skills in every form or fashion, in every facet, of the vascular space. And yet they're the ones that are leading the charge in these studies and cherry picking the patients that they're going to include in the study. So you have to be very, very careful. I've seen with my own eyes, when I see those studies that say it can't be done, it shouldn't be done, it increases risk for amputation, I can only speak to experience of being on the front lines, watching thousands of hours of procedures and following up with patients, sometimes, 6 months, a year, 2 years down the road, and now working through the way to my heart with many of you. We're now almost 5 years into this, and so many people that we worked with from the very beginning that were all on deck for amputation because the doctor said it wasn't possible to treat below the knee, and we were able to get them to an advanced limb salvage specialist who knows how to carefully take those and very cautiously take those wires and balloons, clear down the tibials and the perineal into the pedal loop in the foot. And these patients are still walking today. And it's amazing. You'd never want to go with a doctor that's going to do it all the time or do it too much. You really want to make sure that you are truly in need and your limb is in jeopardy when you do get that done. But I also argue that from my experience, I can only talk from my experience, and I'll have doctors that will come after me and probably criticize this video because I'm not a doctor. I can only tell you, being a journalist and being a trained journalist, I'm really great at observation. I'm really great at capturing the essence of what's happening and paying attention to details. And with my experience, the doctors were actually treating my camera as if it was a live case, as if they were broadcasting step by step the entire case from the moment they would puncture the artery, start sending in the wires and balloons and the contrast fluid and intravascular ultrasound. And so I learned a lot. I would take all of that video and I would listen to it, replay it for hours and hours, learn the lingo, watch replays of how they were navigating even the most complex lesions in the vessels and still being able to be successful and to restore blood flow. And so I feel like I have a unique experience. Some doctors have even said I've been in more cases with more doctors than they have. And these are some world-renowned doctors. and that highly respect what I know and what we do. I will never claim to be a doctor. I will never, claim to know everything, and I could never do what they do. I can only share with you what I see. And what I see is the fact that it is possible to treat below the knee. It is possible to treat those vessels in the foot. It has to be when it's medically appropriate. That is left up to, that's where you're going to find differing opinions across the board. It's why we say to always get a second opinion, because the different doctors, different approaches, different tools, different techniques, different philosophies. And just because you trust them, because they're at a large hospital with a big name, it doesn't mean that they're the right doctor for you with the right skills. It's worth making sure that you ask the questions about their skill set. Are they more conservative in their approach? Do they believe in just going in, tiptoeing into the vessels, and a less is more approach? Only stenting when it's critical. Stenting is not frontline treatment. If a doctor says, oh, we're going to go in there, and they use the word stenting as if it is the treatment you're going to get, it's a red flag. Now, I'm going to tell you the exceptions to the rule. The heart, the aorta, the iliacs, usually pretty much guaranteed you're going to get a stent. But lower in the legs, when you're talking about blockages in your common femoral, your that's at the bendy part, into the thigh, into the knee, below the knee, they don't know until they go in whether or not a stent might be needed these days. It used to be they would stent everything. Everything would get a stent. It just was part of the protocol. In fact, I was at a large hospital, and we went in and they were trying out a new device, and the doctor ended up saying, nope, we're not going to treat this patient. And we're thinking, well, why aren't you going to treat this patient? We just saw a similar presentation of disease at another facility just down the road. So why is it that they were able to treat it there and not here? And the doctor says, well, standard teaching protocols indicate that if you can't stent, or we can't stent a particular artery, we can't treat it. So we send the patient to amputation. That patient did not know that just down the street, another doctor at a different facility, might not have been a well-known facility as this present facility that they were in, but a different facility that that woman would have walked out that day with her leg. And instead, she had her leg chopped off, having no idea. The doctor said she signed the document giving them clearance. If you get one of those documents when you go into a procedure at a large hospital that says, hey, I'm giving you, the doctor, permission that if something goes wrong, that you can just, or we can't get through the blockage, that you can just amputate my leg. It is best to take a deep breath and maybe put a comment in there and say, I would rather be woken up to have the discussion. The exception being, if my life is on the line, whether I sign this document or not, if my life, it's going to be life or limb at that point, they're going to take your leg whether you sign that or not. So it doesn't matter. They won't tell you it doesn't matter whether you sign that or not. If you don't sign that, you at least, and I think, Alan, you know this, at least you have a chance to be woken up. You can ask the questions. You can make the determination, you know what? I want a second opinion on this. I want a different set of eyes on this. You might be an amazing doctor, the best in the world, but what if someone with a different set of eyes, a different set of tools, a different set of techniques might have a different trick up their sleeve? They might be part of a research study. Not every doctor is a part of every research study, right? And
exactly right. I do remember we began our journey in trying to save my legs in August of 2022. And it took 3 different doctors to do that worked on me for the next 3 months. And I do remember that. And all of them had a different set of techniques.
And they don't have to be more or less, better or worse. They can just be different. I remember when I was following that FDA clearance process with that laser had the ability to get through 100% blockages. 100% blockages are the reason that people get their legs amputated in this case, right? If you have a
Yes.
100% blockage, they can't get through it, then you're going to get amputated. If you don't have enough collateral vessels and you have wounds that won't heal, they're infected, there's gangrene, and your leg's cold, they're going to have to amputate. So what this laser could do is the laser could actually get through, I think they had a 94% success rate in getting through some of the toughest blockages. And so one hospital would have this laser, but one next door did not. Maybe one doctor in one facility would have this laser, but another did not. And they didn't know that this other doctor had this laser and was part of a study. So that's why it's so important that no matter what ails you, go and check with another doctor and even say to your current doctor, say, you know what? I believe in you. I trust you. But what if someone just has a different tool or technique or is part of a study that neither of us may know about? And you were mentioning below the knee, which is how this conversation really began. There is so much happening below the knee. And those doctors that may not have felt the technology was available or that their skill set was enough to be able to traverse those small, fragile vessels below the knee and the foot in a way that would be durable, I think you're going to see more and more of them giving in and saying, hey, you know what? Wow. I think technology has risen to a place where I think I feel more comfortable. And even doctors that might not have the best, finger skills to be able to navigate these vessels, they might have just an easier time with some different types of tools that might make up for where they fail with their hand skills. I know that I think, Alan, I think it was either you or our friend Douglas that had brought up in a previous conversation with vascular surgeon Dr. Devin Zarkowski out of San Diego, bioabsorbable stents.
Mm-hmm.
And they're being tested, the ones that absorb right into your vessels. That those are even coming out, which may change people's ideas on stenting. It's a different type of stenting, right? It just absorbs right
Correct.
into the
I think
body.
they're being tested. We're in Europe right now. I believe so.
I think some of them might be cleared in Europe. Um, and I think that they're starting their clearance process here. So we'll have to get the company to come on to talk about what their path to market is for folks here in the US. But there are a lot of new technologies. There are even new roto-rooting technologies. The roto-rooting technologies, or what we call atherectomy, they're also evolving. They've been highly criticized because they get reimbursed at high levels, which happens with every newer device. But usually, I mean, I would think there would be a timeline in which when they price these new devices that come to market, they price it in a way that would incentivize doctors to try and use them. They say, hey, you know what? Here's a new device. It's cleared the FDA process. They have pretty good results. They want to incentivize people to try them. But sometimes that incentivization plan can be abused. And rightly so, some newspaper reporters have come out and said, hey, you know what? We're going to raise a red flag here to say that there are some people that are using these devices at 2 to 3 times the rate of other people. Now, there are some factors with some of the doctors that I've seen on the list of high users or high volume users of these devices. And I know for a fact that they just simply have more days in the cath lab. They're in very high risk areas with really highly complex patients, and especially patients that have below the knee disease. And so it does make sense that they might have a higher volume of usage. But I will tell you that I have been in cases where I'm not quite sure if the doctor's actually placed a device they've opened up inside the vessel, because usually with an atherectomy device, most of them you can hear the sounds, you get very familiarized with the sounds. If you've ever been in a procedure, you can hear,
Oh yeah.
you know, a couple of them are a little disconcerting. You're wondering, like, are you sawing off my leg
Like
right now?
it's
What
like,
is
why is my
really
leg
happening?
vibrating?
What's vibrating?
Right.
And so it's really important with that. That's why we always say to patients, before you go into a procedure, don't just accept the fact that you're having an angiogram. There are a lot of questions that you need to ask, not only about skill set, but what are the tools you plan to use and why? Why are you using those tools? Do you take a less is more approach in treating my vessels? And what is your success rate? What are the contingency plans? What if you can't get through a blockage coming down from the top where they poke in the groin? Do you come up from below? Will you poke in to an artery in my foot, in my calf, or behind my knee and try and come up what they call a retrograde approach, coming up from the bottom? Because sometimes if they can't break through, these blockages typically have a cap on them, a hard cap. And if they can get through that cap, it might be more, the plaque below might be more amenable, and there might be a little pathway to get a wire. The whole key to these treatments right now, and actually why I liked that previous laser, the previous laser did not rely upon a wire guiding it, but every other device on the market right now requires that a wire actually be able to penetrate or traverse through a blockage or a narrowing in the artery in order to be able to treat. Now, sometimes they'll go into the artery wall, and that's what we call going subintimal, right? They're poking into the artery wall and they're creating a new channel. Those aren't typically as durable procedures as doing what we call going, true lumen or in the native vessel or in the main part of the vessel, but that's not always possible. And if they can try it to get blood flow and at least give you time, all of these procedures, every single one of these procedures to treat blocked arteries, it's temporary right now. And the goal would be is to make them more durable. And as we move forward and the technology I see coming to market now and over the course of the next 5 years, I think we're going to see higher patency rates, more durability. It doesn't mean that you as the patient should not be a partner in your program. You've got to do your part. With peripheral artery disease, there is so much that you can do to prevent and also to stall progression of this disease. So much. The medications, doing as prescribed, lifestyle modifications, and especially walking. I know it's easier said than done, and it's painful. But if you think about walking through that pain and with every single that hurts, that your body is responding with a new collateral vessel that is dilating and helping to reroute blood flow around that artery. It's that pain. You've got to say, you know what, thank you so much, for telling me that you are building my collateral network of vessels. And so right now, when it comes to these treatments, I like the less is more approach, if at all, if they're going to treat it all. First and foremost, always walking, always trying to see how far you can get first. But then saying to the doctor, great, you know what? I just need that much more blood flow, a little kiss of the balloon. Less is more, conservative is better. Tiptoe in, doctor, and just give me that much more blood flow so that I can walk further without pain, so that I can continue to build my collateral network of vessels. That's still your body's best protection against amputation, is those collateral vessels. We have people that have had their blockages opened up, and then they close up a few months later or even a year later, and yet their test results for their ankle brachial index, that's the ABI test where you have the blood pressure cuffs on your legs and your arms, and they're still pretty high at 0.8, 0.7, clear up there. And that's really good. And it's because of their collateral network of vessels. And people ask, well, should I get treated? Because they're just scared that, well, what's going to happen, down the road? Is it going to get worse? Well, you know what? It may or may not. But at the very least, those collateral vessels are more likely than not going to sustain your leg if you can keep walking. At that point, when that blockage is there, you will have built all these collateral network of vessels, and you may not even need that main artery to live your life and to have a good quality of life. So, but I do think that we're going to see these angiograms, all these procedures actually become more durable over time. We even had patients that I've still followed up on from that laser from 5 years ago. Actually, gosh, wow, even more than that, 7 years ago on one of them. And one of them is in Canada. And this gentleman, he's been on our program before a couple of years ago. He was told by multiple hospitals in Canada and 2 university hospitals in Michigan that he needed bilateral AKAs, bilateral being both legs, AKAs meaning above the knee amputations. And he was able to work with us to get to the middle of nowhere in California that just so happened to have this laser device. And it was able to get through the 100% blockages in both legs. It is now, I believe, 6 years or 7 years later, he still walks 4 to 6 miles a day and has not had another procedure since. So it gives me hope that as we continue to attract more entrepreneurs in this space, greater innovation, you've got to incentivize these companies to innovate. You've got to incentivize these just new techniques. We don't have a cure. Until we have a cure for peripheral artery disease, we have to do more to incentivize not only the development of these devices, but the use of them. Now, that being said, there are always those cases that abuse the system. And the federal government does need to keep watch on those doctors and does need to crack down. We do need the watchdogs to say, hey, wait a minute. You're using these devices at 2 to 3 times the rate of everyone else. Are you just doing it for the money? Very important to have this watchdog scenario in those situations. But still, those doctors are the exception to the rule. I would argue that most doctors are really trying to do the right thing and are excited about the new technologies, are using them when medically appropriate. And I hope that the newspaper articles that have come out recently condemning, the innovation and the people using it and the pioneers in this space, I hope it doesn't deter innovation going forward. But at least for right now, I do have hope. I'm seeing a lot. I'm hoping to bring more for you next week. I'll make sure that we get doctors on that can talk about what they're most excited about in innovation at this next conference. So stay tuned for that.
Excellent.
Did I answer your questions?
Boy, that was a good one. That was a long question, wasn't it? Too many points. The reason I asked that was I'm experiencing a lot of that myself locally here. As you know, I just lost 5 of my doctors.
Wow.
And a ultrasound tech that has been taking care of me for 15 years. So with this new doctor in our local hospital, he's really fighting to get those devices so he can help more people. And one of those people is me. I need a laser. It's the only thing that will remove what I've got going on. Also, I'm seeing more acceptance in the local vascular field, even though my doctor's retiring. That doctor couldn't get through a blockage. He called on this other new doctor to, hey, can you do anything?
Mm-hmm.
And 2.5 years ago, my doctor, my vascular surgeon, was not real big on this type of treatment, the endovascular treatment of below knee. He was more of the, it's going to happen anyway. Why not just do it now while you're young so you can live with it?
Yep.
So even he's coming around, even though he's retiring. His wife was really into it and used it. I think worked on him a little bit. But yeah, just locally, I'm seeing some changes. And it's not a big hospital, just a little regional hospital, but I'm seeing some growth.
And I'm seeing the same thing. And you had asked, I think, in part two, or was it part three of
Ooh,
your questions? We are seeing some hope coming out from the next generation of doctors. So many young doctors that are adopting and excited about the new endovascular approaches. We have this next generation that grew up with technology. They love technology. They embrace technology. Everything and anything, this Apple age of doctor that grew up with Apple, coming out with the new innovation every year and adopting the new phone every year, getting the new computer every year to 2 years. I think that they're going to be more amenable to new, more cutting edge approaches, techniques, and tools as we move ahead. We're already seeing that across the board. And it's really exciting. At this conference that I'm going to at NCVH, the new cardiovascular Horizons conference in New Orleans, they have an entire fellows track, which Craig Walker, who is the founder of this conference, allows me, and he'll escort me in and get me, set and introduced to the different fellows so that I can follow them on their track to being able to try out some of the demos of these devices. At one point last year, I had the opportunity to actually deploy what are called tacks. And it's a newer type of stenting device. It's more like a staple. So you don't have a full long stent. It's just this little, it reminds me of just a staple. You just deploy a tack to, so let's say you dissect a vessel where it peels back a piece of the vessel that's hanging down and blocking the artery. Well, they can go in and instead of putting a big long stent, they have a tack and they just pop it in there. And I was able to deploy one of those in a simulator. And so that was really fun. And it taught me, just that. I also had an opportunity to work with another device and learn how to use. It's from it now. Abbott owns it. It's a 360 device. It's a sander. It used to be from Cardiovascular Systems Incorporated. It's an orbital atherectomy device. It's like a sander. And I was able to demo one of those. I even had the opportunity recently. I haven't actually released those pictures, and it was last summer. I have had the opportunity to go down to UCLA's Lundquist Center, and they have a lab that was put together by David Chalian, who used to work for Philips. And it was a testing center, a training center for some imaging technologies. And I was able to go in and use the imaging device. Called ICE, and I was able to navigate it through a pig's heart. And it was incredible. It was such an incredible learning experience. But it was exciting to see these types of facilities popping up for fellows to be able to go in and go beyond their traditional textbook and university setting and actually get outside and have more hands-on experience in these labs with these devices. And so I think that that's really exciting. The one thing, and I think this also addresses, you were asking about the different doctors and accepting of the different practices. There are 4 different types of doctors in this space. Vascular medicine, whom I love. If you ever have a vascular medicine doctor that you can find to manage your medications, your lifestyle modification programs, they are fantastic. And some of the other doctors that are surgeons or practitioners, they also may have an extra certificate for vascular medicine. And so it's always worth saying, hey, do you have a vascular medicine credential? And we're seeing more and more. I think it was started by the Cleveland Clinic. And so
Mhm.
they'd offered a certification program for that. I really like vascular medicine doctors, especially for early stage PAD patients. Number two, you do have vascular surgeons. Vascular surgeons traditionally handled PAD, and they were trained initially in open methods. It wasn't until there was a situation in Oregon where a patient, I think she might have been in her 80s, she had a blockage in her thigh, and the doctor said, well, we're just going to have to amputate. I can't get through it. You're not a candidate for bypass. And she said, I'm not going to have amputation. So this surgeon went to their interventional radiology department. Interventional radiologists at their core are literally groomed for using wires and other minimally invasive devices to go into arteries, especially for cancer patients. And they also perform minimally invasive procedures for dialysis patients and things like that. So the doctor said, hey, why don't you try using some of those wires and catheters and whatever you use for some of your other things to go in and see if you can open up this artery? And so the very first endovascular procedure on the leg was performed in Oregon at a university there. And what they did was they were able to size up catheter after catheter after catheter. So they just kept inserting a larger catheter and then a larger catheter and then a larger catheter to push that plaque aside. And they were able to open up this woman's vessel in a minimally invasive way. And that was an interventional radiologist. Now, then you have interventional cardiologists. They're also groomed and trained at their foundation in using wires and balloons to open up the most complex lesions in those tortuous vessels of the heart. And with the heart, that's a moving target. Imagine with the legs, it's a little bit more of a straight shot and the vessels are not moving, right? So you could imagine that these doctors that are navigating, the heart would be appropriate to be able to also navigate those leg vessels as well. And so interventional cardiologists started getting into it. And in fact, they've been pioneers in minimally invasive procedures. I mean, some of the greatest technologies that have been created for minimally invasive approaches have been, including the balloon over the wire, have all been created by an interventional cardiologist. Now, there are a lot of interventional cardiologists out there. There are a lot. There are a lot more interventional cardiologists, but not all of them actually treat the legs, and not all of them I would want to treat my legs, because some of them, in my experience, in observing cases, treat the legs like they do the heart. And with the heart, you need to go in and you need to pump up that balloon hard and fast, quick, because if you keep that balloon opened up for too long, patient's dead, right? But with the legs, it seems like those vessels are a little bit more fragile. They're not moving. Leaving the balloon open for a longer period of time, it's not going to kill the patient. And so we have found that a lower inflation, slower inflation, and a longer inflation time seems to lead to greater durability. And so, we some of the interventional cardiologists need to adapt, to that as well. And they do over time. So if you do have an interventional cardiologist, it's good to ask them and say, hey, do you treat the legs like you do the heart, or do you adapt to a more conservative, less is more approach, making sure you use lower inflations, slower inflations, longer inflation times, and see what they say. It would be interesting. A doctor that you don't want is one that wouldn't answer that question. The doctor you do want is one that will say, wow, where did you learn that? Yes, of course I do this. Of course I use a less is more approach. Yes, that's better. Less chance of perforating or dissecting the vessel. When they pump the hell out of that balloon, what's going to happen? What happens when you literally blow up a balloon too fast?
Dissection.
Correct. It just pops. So you just think about it that way and understand the importance of choosing a doctor that has that less is more approach. Now, again, you have vascular medicine doctors, interventional cardiologists, interventional radiologists, and vascular surgeons. And right now, what we're seeing and what you'll hear a lot about, and I get it every single day with our Leg Saver hotline, with people calling in, it's with this, there's a turf war. And the practices hate when I call it a turf war, but you know what? Journalist at heart, I'm an observer, and I have to call it like I see it and I experience it. There is a turf war. And it's not about, they all want to say that their way is the best way. Their way is the only way. But the fact of the matter is, with the diabetes going out of control, 1 in every 2 adults being pre-diabetic, diabetic, and a top complication being peripheral artery disease, there are more patients than there are these specialists to go around, even with all of the practitioners combined. There aren't enough to go around. I have patients in North Carolina waiting for 3 months to even with lifestyle limiting claudication that are on the verge of quitting their job because they can't handle the pain and they can't do their job. And they can't get in to see their doctor to get a treatment for 3 months. And so we need all hands on deck. There is no time or space right now with what I'm seeing for any turf war. It is time for everyone to come together. And I want every one of you, if your doctor speaks poorly of another practice, I want you to say to that doctor, hey, do we have, can we really afford to lose even one doctor right now? Doctor, are you in that desperate need for patients? Is your dance card not full every single day? It took me 2 weeks to 3 weeks to get in here. If you're that hard up for patients, well, then why couldn't I get in here the next day? We need all hands on deck, and we need greater standards. The American Heart Association and the American College of Cardiology and a bunch of the other societies all came together and have actually released some new standards, which I'm really excited about. Stay tuned over the next couple of weeks. I haven't wanted to talk about them because I don't want to speak out of turn until I talk to the doctors that helped to lead the charge in creating them. And we have that in the works to bring those doctors. And we're going to have doctors from every single one of those practices that are going to be present and showing you how their collaboration and their communication is leading the charge for the next generation of treatments for PAD, which also gives me so much hope. But as it stands right now, we have a shortage of vascular surgeons, and it's still the #1 referral. So almost every single time unless a patient's already with a cardiologist or an interventional cardiologist for their heart, the podiatrist and the primary care always refer to vascular surgery, not understanding that other doctors within the hospital might have the same skills or a different set of skills that treats peripheral artery disease. But the fact is, we don't have enough vascular surgeons to go around. And I know some very talented vascular surgeons who I have literally flown patients across country to actually go see for very complex cases where they need a hybrid approach, where they need a doctor that knows how to do both endovascular and surgical technique. And they really needed that dual set of skills. But 30% of hospitals across the US have job postings for vascular surgeons. And especially in the rural communities, we have experienced one vascular surgeon on call for 3 to 4 hospitals within this 2-hour radius. And we had one patient unfortunately pass because that one vascular surgeon, she had an acute situation with clots in her leg, and the vascular surgeon was handling another emergency 2 hours away at another hospital. And we were able to help her coordinate to get a life flight up to UCSF in San Francisco, but it was a little too late. And so we need to have all hands on deck. We need to have a meeting of the minds. We need to have doctors actually just say, you know what? If I can't do it, and if I don't do it, it doesn't mean it can't be done or shouldn't be done, and be willing to give up the patient to other doctors and be able to collaborate and, again, have a meeting of the minds with other practices and just for the betterment of the patients, because as I said, we can't afford to lose even one doctor who has an interest in treating peripheral artery disease.
Well, you hit all
Other,
that right on the head. Thank you.
oh, good, good, good. Anyone else have some questions? I see quite a few of you in here. Feel free to unmute and speak up. Any questions, any insight, comments, experiences that you'd like to share?
Hi, Kym. I'm Dawn. We've spoken on the email, but we haven't spoken like this. So
We
it's
have.
nice to it's nice to see face to face, as it were, right? Um and yeah, there's actually a couple of questions that people have typed that you might want to have a look at yourself. But you're the expert, so I'm very still quite new to this. So if people have a wire put through their artery to open it up, do they always have to have a stent? Why does the artery kind of collapse? What happens?
This is such a great question because you don't always need to have a stent. And there are some doctors that have been in the business for a very long time. There are even some that may have just graduated, from university and their fellowship, and they're just used to stenting. It's just part of the training protocol. They have to place a lot of stents to really learn how to, get them in there properly. And important. It's definitely an art, right? As much as it is a science to be able to do that. So they have a lot of practice and they fall back on what they know. But the new philosophy when it comes to stenting is less is more when it comes to the legs. If you're going to have a heart cath, if you're going to have your aorta opened up, if you're going to have your iliacs opened up, all in your abdomen there, the stents are usually a guarantee. They're areas that stents don't seem to block up as quickly. When it comes to the legs, which are moving all the time, the stents do close up very quickly. And there are a lot of reasons for it. The number one reason is that anytime you put a foreign object inside your body, it's going to trigger a healing response. And some people, especially when you're younger, you're going to have a quicker healing response than someone who is older. So the key is making sure that you understand the reason that you're going in and the reason you're having that artery opened up and the reason you're having that stent potentially put in there to make it last just that much longer is so that you get enough relief so that you can get out and walk more, further, and faster to grow your collateral network of vessels. So when that does close up, and it's not a matter of if, it's usually a matter of when, because of that healing response, you may not need another procedure, at least for a long time, because those collateral vessels have grown and they're able to feed your leg with enough blood flow. Now, that being said, another reason that we've seen these stents block back up so quickly and is because they're not sized properly. And what happens is in many cases is the doctors are just relying upon a 2D image and just their eyes and feel and experience to be able to properly size and place that particular stent. And it's not 100% accurate. So we have patients, for example, that have had stents placed in their iliac arteries. And that is the place I said that it's more durable, right? And that's why you pretty much, if you're getting your iliac arteries done, more likely than not, you will get a stent placed. But they may not be durable because the doctor did not size that stent properly. Might have put a stent in there that's too small or too big. Usually what we see is that they place a stent that might be too small in there. And so it just keeps blocking up. we like a doctor that goes in and uses a device called an intravascular ultrasound, or IVUS. And it uses audio waves to give the doctor a better idea, a more accurate idea of the morphology of the plaque. I love that word, morphology. Morphology of the plaque, the type of plaque. I love when I get a doctor that calls me and says, one of your patients, I had to talk to the person that taught my patient the word morphology. I have never in all of my years heard a patient use the word morphology. And I love it because I just think it's fun. But you're just basically talking about the type of plaque that's in there. Or do we have clot? Do we have fibrous material? Do we have rock hard calcium? What type of plaque is in there? They can really get a good idea when they go in with this IVUS, intravascular ultrasound. The other benefit of IVUS is the fact that they can better size the vessel to be able to choose a more accurate size of stent to place in there, right? And so that being said, we're going back to the less is more approach, and with the thigh and with the knee and below the knee arteries, usually doctors are erring towards less is more, and they realize that if they go in and they don't do a lot of trauma to the vessels, meaning going in there and pumping the heck out of that balloon with high inflation rates and that kind of thing, and taking their roto-rooting devices, the atherectomy devices, and instead of just kind of going in there, maybe burrowing a hole through, maybe taking a couple passes with that device to sand it down a little bit or laser it a little bit. Instead, they're going back and forth and trying to do what's called, maximum luminal gain, trying to get as much of a pathway through there as they can. And, that could traumatize the vessel even more and trigger the healing response much quicker. And you have a greater chance of damaging the vessel, perforating the vessel, dissecting the vessel. And in those cases, yes, you need a stent. And so I always say, go in, tell the doctor, I want a less is more approach. If you're treating, I tell people, know where your blockages are before you go in. So you can have this productive conversation with them and say, in my thigh, is it possible for you to just go in, tiptoe in, take a less is more approach? If you feel like you need to take out some of that plaque, let's say it's rock hard calcium, the orbital atherectomy device is indicated for rock hard calcium. So a doctor can go in and maybe sand down a little bit of that plaque, which makes it more amenable for the balloon to be able to expand just a little bit more. They call that preparing vessel preparation. And that's mainly how we think that these atherectomy devices should be used. There are also other types of these vessel preparation devices that are actually making it so they can use fewer stents. And one of them is a lithotripsy device. And they use those sound waves to just crack the plaque. And then they follow up with a drug-coated balloon where the drug can seep into the little cracks in the plaque and get closer to the vessel to soothe the vessel. And they're actually cancer drugs, paclitaxel, and the other one is just escaping me right now. It's a newer one, but it actually is making it so that the vessel won't trigger that healing response as quickly. So maybe a stent may not be needed in those cases. So it's not a matter of if the stents are going to block, it's a matter of when. So if you can work with your doctor on a less is more approach, I think that's always your best bet.
Yeah, so it sounds like they don't have to be completely open, do they? They just have to be a bit open,
Right.
right?
You need literally just that much more flow.
Mhm.
in order to get you that much relief so you can get out and walk and grow more collateral vessels.
Yeah, yeah. For me at the minute, I was told by my surgeon I could make it a little bit better. That's what he said. Well, I've done that, you know. And so now I'm thinking, okay, what else can we do? Because I'm still limited in what I can do. And so I'm going to see this other surgeon that you recommended, Bar, the man in London. And in a couple of weeks, going to have to talk to him about it. And he's also being quite nervous about it and saying, well, it depends. And as we all know, as soon as you touch an artery, you're going to damage it in some way.
Yep.
But I'm going to see him and we're going to see what we can do. But like I'm sure for everybody here, when you've been in a really bad situation, if they can make it even just a wee bit better, you feel like, oh, it's fantastic. And so I'm still hopeful. Maybe there's something possible, but it's great. All these things you're saying, Kim, I can go and talk to him and understand, okay, what's possible, what isn't, and also manage my own expectations about what's possible, in fact. So it's grand. So I really appreciate what you do, Kim.
Thank you. And it's interesting when it comes to peripheral artery disease that everyone's presentation is different. And so,
Mm,
with the guidelines that are out there, not everyone fits into the box, right? We had Dr. Devin Sarkowski, who's a vascular surgeon, who came on recently, and he said that while everyone is condemning doctors for treating what are called intermittent claudicants,
mm,
that is an early stage of PAD
mm,
in which a patient, it's defined by a patient where they can walk, they get a cramp, they try to push through, and when they can't go anymore, they stop, they rest, pain goes away, and they walk again.
indeed, yeah.
And the whole theory behind not treating them is that there's still so much patients can do in order to improve their prognosis and delay having a procedure, never even having procedure in so many cases, actually, in most cases. But there are exceptions to the rule. For example, if your job relies upon you to walk, 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 and you don't have that time to rest, and your safety might be in jeopardy or your job might be in jeopardy because you can't consistently walk, and that cramp at some point within 5 to 10 minutes literally stops you in your tracks, then that might be a reason for you to have that discussion with your doctor to say, hey, I think I'm the exception to the rule. My lifestyle is limited. I might be an intermittent claudicant. My lifestyle, my livelihood is
Mm,
limited by this cramping. Can you go in there and just kiss it with a balloon
I
to
like
give
that.
me just a little bit more flow? It's actually a technical term. Say that to your
Oh,
doctor.
really?
I dare everyone. I would love to hear, because that is a term that I heard over and over and over again. I'm just going to
Okay,
kiss it with a balloon. Just
right.
going to kiss it with a balloon. And so there are other situations he mentioned as well. And I had never thought about this. He has patients that are in cardiac rehab that
Mm,
the PT, the physical therapist, will come to him and say, this patient is not getting the cardiac benefit of this therapy because they have to stop walking every 10 minutes. I need
mm,
them to walk at a brisk pace, get their heart rate up for 30 minutes to get them through this PT and make it effective. And in those cases, it makes sense to just go in and kiss it with a little balloon, just to give that patient a little bit more blood flow so they can make it 30 minutes to get through cardiac rehab and get those benefits.
mm, mm. Okay, that's great. Thank you, Kim. I'm going to go and tell him to kiss it or something like that.
Make sure you say kiss it, don't say kiss that. Um, or
No,
kiss
that's grand.
off. That would be
Yeah,
good. But
we'll see how the
it's so
conversation
great
goes.
meeting you. I look forward
Yeah,
to
really
hearing.
nice. Thank you.
And
Thank you. It's really grand.
I hear we have a question from Margot from YouTube. Is there a way that the hospital can measure the growth of collateral vessels in my peripheral artery disease or PAD? And you can definitely If you're growing those collateral vessels, you should be able to see the difference in your results, in your ultrasound. We even had someone that came to me that said that despite a blockage in her thigh, her ABI, her ankle brachial index, actually improved with her walking and the growth of these collateral vessels. Even more, the only way to truly visualize them, but we don't recommend having the CT scan, the CT angiogram a lot because it, the exposure to the radiation and the contrast fluid, and especially for patients who have chronic kidney disease, that's not a good thing. And so we don't suggest doing a CT angiogram just to see your collaterals. Ultrasound should be suffice, but you can actually visualize the collateral vessels if you've been walking and they're growing to reroute blood flow. You can see them visually on a CT angiogram. And I always encourage patients who have even had a general angiogram where they were treated with angioplasty or the like, or they just have the CT angiogram, to snap some shots of those images and share them with us and share them with the group and show me your collaterals. Show me those little lifesavers and leg savers that you're building through walking. I think it really does inspire other people to actually see them. Marie has a question here. Why do doctors not like to remove stents or bypasses that are no longer working? The issue with removing some of these is because your body has already absorbed them. They've already, grown scar tissue, things like that around them. They're really difficult to remove. When it comes to stents, most stents cannot be removed anyway. They literally just get enveloped into the artery. They become kind of almost a part. It just grows kind of around it, with the scar tissue and stuff. So it does make it really difficult to remove it. If there is a situation where you end up with an infection in a graft, that's a pretty big issue, and they do work hard. It is risky to remove a bypass graft, but they typically don't like them to be removed because there are a lot of risks in taking something out of your body once they've already placed it. I know that in some people that have had allergic reactions to the stents, I don't know if this is standard protocol or product guidelines, but I've seen it done where they've taken a covered stent and placed it over a bare metal stent to reduce the inflammatory response and healing response that would cause an artery to reblock in a particular stent. So, but most of them, they don't remove it. That's why the bioabsorbable stents are becoming more and more exciting. And I think that that's something to look forward to see if that actually improves the prognosis for patients. Are there any other questions coming in? I see quite a few of you still on here. Go ahead and unmute and ask the questions. I'll stay on for 15 minutes more to answer questions. And then I'm going to have an afternoon with my dad. We're going to do errands. So I love having my dad around. It's really nice. Nancy, you have a question.
Yeah. I'm doing 10,000 steps a day on a treadmill with my daughter. Is that good? That's about all I can handle. I've been doing it for about a month and a half now. Do I try to strive for heavier? Or farther, or am I good with that?
I think that's amazing. And Josh, my producer, chimed in. That's amazing. It's really up to the individual, and it's something that you need to discuss with your doctor in terms of what are your goals, what should you be striving for, where are you at right now, and what's realistic for you, and how much should you push it, what's the health of your heart, what's your blood pressure like. There are a lot of factors that go into determining, how far, how fast you should be going. But my question for you is, 10,000 steps in how long? Are you spending 30 minutes? Usually doctors try and figure out how far you can go and how long.
4 times 25 minutes. And the first 20 on my treadmill, I do at 1.5. And then the last 5, I bump it up to 5.5, I guess it is, whatever that means in speed. So
So it sounds like you are walking an hour every day.
Yeah, well, actually 25, 50. My math is terrible, Nat.
Oh,
25,
wait. 20, oh,
20
wow. No. You're
25
you're
minutes a
going
day.
2 hours a day. You said 4?
Yeah. Yeah,
Oh,
we're
you're going
doing
4
4 times
25-minute
25.
sets.
So that's 50. That's 100 minutes. That's an hour and something. Ellen, you're probably better at math than I am. But anyway, so we do it like in the morning, in the afternoon, around dinner time, and again 7 o'clock-ish or so. But I had a really bad day yesterday, and I don't know why. It just occasionally it comes on. Not much I can do. Take a Motrin and hope it goes away.
Mhm.
But we see Dr. Minkus next Monday, not this coming Monday, but the following Monday. It'll be the first time I've seen him since he said there was nothing that could be done. So I'll wait and see. But I also have an Apple Watch, and it checks my heart rate and everything as I go. And that's all been great. No problem at all there.
Oh, that's fantastic. And the fact that you're doing 4 different sets of 25 minutes is a really good thing. The other indicator that you want to pay attention to is, what is your claudication time? Dr. Anita Dubois, who is a vascular surgeon at Mass General in Massachusetts, she has done a lot of research on walking as medicine, and one of her um, focuses is on the claudication time. Claudication time is the time between the onset of your pain and how much you can push through that pain to stop. What is that time in between there? Between the onset of your pain and the time at which the pain gets so bad that it forces you to either slow down, and instead of slowing down, you stop, you rest, you regroup, get relief, and then you walk again. The other one is your time to rest, and that is the time you start to the time that you stop and rest. Do you stop at any point during that 25-minute walk?
No.
That's incredible.
In fact, we speed up, as I said, toward the end. I do 20 minutes at 1.5. And then the last 5, I have to turn up to 2. I think it's 2.0 or something. Anyway, so
When
I
you are walking, do
Uh-huh.
you walk conservatively as to prevent the onset of cramping, or are you trying to walk at a brisk pace
brisk
to
pace.
trigger that? You do walk at a brisk pace.
Yeah.
The key is, what we find with so many people is that they say, oh, I can walk 30 minutes, but they're not walking 30 minutes at a brisk pace. They're trying to walk conservatively so that they can at least make the 30 minutes without stopping. The key to building collaterals is to walk at a pace that is going to trigger the claudication sooner rather than later. I want you to thank that claudication for coming on the soonest it can, if it's going to come on at a brisk pace, and push through that as much as you can. And the more you're feeling it, the more you're thanking your body for responding with those collateral vessels you are growing. Now, I think peripheral artery disease patients are the strongest I've ever met, strongest humans on the planet, because the pain that you're enduring and the claudication, I always tell people it is like their very worst Charlie horse, where the Charlie horse is so bad, it forces your toes to curl and feels like your leg is just going to break off if you even move a muscle. Is that
Right.
fair?
Yeah. I don't have the severe pain. I did for 4 years when I was trying to find doctors, chiropractors, laser, anything. And I don't have that pain now, but I just have discomfort at times, which I'm hoping means my collaterals are growing. And I also still have numbness in the pad of my right foot, but I'm beginning to feel a little numbness in the left foot. And he said the left leg was completely open, but I want to, he'll do a reading for me when I go there Monday and just see if it's still open. And I think hopefully the exercise has caught that before it got really as bad as the right. But the right foot, the tingling and in the pad below the toes are like numb, but
Right.
it's just it feels like it's swollen, but it's not. So I've used BioFreeze, I've used Bengay, which I used on the farm for years, kind of like the bacon that we talked about. And anyway, it's just, but yesterday it's set up, but the day before, in all fairness, I was at an event that I was hosting for the Chamber of Commerce with vendors, and I walked around and around about 100 vendors there. So it could be that it just was a day of overdoing it.
Yes.
So
And I think that with CAD, you have ups and downs, and it sounds as though you did a lot. It's very easy when you have PAD to be very sensitive to those bad days and to think, oh my goodness, is it getting worse? It's
yeah,
important to be very aware of it. And that's why I usually like to have people join our walking program. It's a text-based program. For people here in the United States, it's free. It's at no cost to doctors. It's at no cost to patients. It's really important that you go to your doctor and say, you need to sign up for this. They get a free dashboard. They can monitor your walking. And what's even more important, the way we designed it is that there's a symptom tracker. And so you can actually, after your walk that day, you can type in what are the symptoms you're feeling, and the doctor can actually see how you're progressing and if symptoms are getting worse or getting better, if there's an addition of a symptom versus a subtraction of a symptom as you are walking more and more. And so I think that's really important. And we ultimately, hopefully by the end of the summer, we'll have an app that will include the opportunity for people in the UK to track their steps as well. But it's important for you to notice when you do have those days, keep a journal, write them down, because the number one issue that we have with PAD patients is that you are so strong and you push through so much and you don't like to complain and you feel like you're not being heard and you're tired of being brushed off for that pain with doctors saying, well, just go home and walk, walk, walk. So you don't even want to go back because you just don't want to be embarrassed. And so a way you can get around that is to start just a little journal. And I don't care. You can text me every single day, email me every day. I'll put it into, we have a new EMR system that's HIPAA compliant. And if you want me to put something into a chart and track things for you, I am happy to do that. We have a team of PAD navigators that are happy to do that for you and help you to keep track. And so when you're ready to go see your doctor, we can actually send you an email with a list of all of those milestones or potential complications that you might have had over the past month or 2 months or longer.
thank you.
So good for you for paying attention to it. But I think in your case, I am so proud of you, Nancy. I've been with you from the very beginning. And I for those of you who don't know, she was on deck for amputation just in January. And this is amazing how far she's come. And it's possible to persevere with PAD. You got to set your mind to it. And I always say that PAD becomes a job. It's a job. You have to be able to work at it. But if you work at it, the payoff is amazing. And the fact that you can hopefully keep, your legs attached.
Thank you.
I have to say, I think that's shocking. I'm really shocked to hear that, Nancy, that they were saying, oh, you have to have it amputated, and now you're walking all this. It's ridiculous. I find it absurd. How can that be? I'm really appalled by this, you know? Because, like you say, Kim, it's because people don't know how to treat it.
Mm-mm.
But what an awful
There
thing.
are a
What a
lot of
terrible
patients.
situation you were put in. Goodness.
There are a lot of patients that, don't walk, can't walk, don't know how to walk. A question I get a lot from patients, and I hear it a lot, is, um, how is it possible to walk through this pain? They just don't know. They think they're going to injure themselves
Yeah.
if they walk through the pain. If you get a muscle cramp, a normal muscle cramp, you can risk tears and things like that. Like, that's what we're trained, right? When we're
Yeah.
younger, oh, you got a muscle cramp, make sure you hydrate, rest, and don't do it. But with
Stop now.
peripheral artery disease, it's a little bit of a
Right.
different cramp, right? It's a
Yeah.
blood flow issue. And so
Yeah.
when you know it's a blood flow issue and you can tell the difference, you got to push through. And I have people that tell me, oh my gosh, why did my doctor not tell me? What the doctors are saying is, go ahead and walk when you feel the pain, stop and rest, and then walk
Yeah.
again.
2 minutes, stop.
It's, you know the drill,
It's
right?
nothing, right? Well, it's
If you,
nothing, isn't it? It's nonsense, you know? And you're like, okay, I can walk to the end of the garden and stop. What's that? That's nothing, isn't it? Huh? I
so
can't
you got
even
to
walk through the
walk.
car park. It's ridiculous. Yeah. So,
Exactly.
yeah. But
Not to the
yeah.
point where you're going to, you got to know the difference. And for each person, it's different. That's why it's tough. There's no real rule of thumb. I mean, I always say, if the cramping gets to the point that you think you need to slow down, that's my indicator.
Mhm.
Then you stop, because slowing down is not going to do any good. You just stop, rest, get back on the horse. But you don't want to walk through so much pain that is forcing you to clench your teeth and
Yeah.
tighten your shoulders, and because then you're creating new problems. We actually had a good friend of mine crack his tooth because he was pushing through the pain so much and he didn't realize that he was grinding his teeth as he was walking. Oh, and he was committed. He did a great job. He's actually avoided procedures for a couple of years, and it's been amazing to see him persevere. But he probably didn't need to push to the point to where he's clenching his teeth. So be very conscious and take it with a grain of salt. Like, make sure, what's right for someone else is not necessarily right for you. So make sure you're pushing it to a point for, that's tough for yourself, but that you're not tensing up and that you're not grinding your teeth, but just using the indicator, hey, the pain is bad enough. I think I need to slow down,
Mhm.
and then instead stop. We have Margot that has another question. I now practice low intensity running for about 10 of the 30 minutes, broken into 3-minute segments. The ABI test showed improvement, but still it says it's moderate. Oh, it showed no improvement of the moderate insufficiency. So words can mean anything. What I would look at is the actual numbers, because moderate insufficiency, it could be on a scale. So you could be at the higher end of moderate, you could be at the lower end of moderate. So I would suggest to take a deep breath and actually make sure of the numbers. Check those numbers, because I guarantee those numbers should be improved if your body is having the normal response of dilating and I use the word growing. Some doctors don't like me to use word growing, but angiogenesis, right? So you end up growing these collateral vessels, is still, I'm going to use it. If your body's not, heeding the response, then you need to see your doctor. You need to do something about it. That may be a time to have the conversation about a treatment, to say, hey, doctor, can you just give me that much more flow? Can you give me a little kiss of the balloon to give me that much more flow so that I can push myself even further and faster? But Margot, it sounds like you're doing a lot of really great things. And I would imagine that there is some improvement in that collateral growth. It does take 6 to 8 weeks for those collaterals to really be able to visualize, especially like on a CT angiogram or such. But that's why they say, do a 3-month time period. And see if your collateral vessels have made a difference for you, have grown, answered the call for help, and are actually bringing you that symptom relief. And doctors take test results with a grain of salt. I've seen people with really, really serious, very complex peripheral artery disease, almost on the verge of critical limb ischemia. And that patient was not, they were still able to walk. They didn't have the numbness, they didn't have the tingling, but they were able to grow so many collateral vessels, but they really were not translating into the test results. So the doctor, all the time, they're going to listen to your symptoms more than they will those test results. Your symptoms are what dictates whether or not a doctor needs to treat. And if you're feeling better and you seem to be improving overall, then put those test results aside and just keep doing keep doing it. But if you do start to see a decline, that's the time to go back to the doctor and say, hey, you know what? It's not working anymore. We need to pay attention to those test results, and we might need to do more. Hopefully that answered the question. I'll take one more question and then we got to wrap up. It sounds like, I don't know, with all these questions, this has been fun. If you want me to do these regularly, I'm happy to do them. If you're learning stuff, you always have to remember that I'm not a doctor. I'm not a clinician. I cannot give medical advice. Always, always, always just take this information as pure education and information that you need to go to your doctor and see if it's right for you. See if it's right for your presentation of disease and get their explicit consent to follow it. So it's really important.
I've got one, Kym. It's on a personal note. What I'm looking at now in the SFA and that jacket of stents that I have all the way down to the knee, it's calcifying now and called grossly patent. What is the treatment options? What do I have to look at when I go to the doctor? What questions should I ask?
You were breaking up just a little bit, so I'm thinking you were saying that you have a blockage in your superficial femoral artery. That's your SFA, that's in your thigh, and it seems that it is growing. It's becoming more and more blocked, and it's becoming a longer and longer occlusion. Those SFA occlusions, the long calcified lesions or blockages, are and have been the Achilles heel for doctors. I always suggest to make sure, especially in your situation, Alan, and it's always an individual's presentation of disease. They could get a different answer from me. They can get a different answer from a doctor, and you might get multiple answers from different doctors as you've experienced. But especially in your situation, you don't want yours to become 100% blocked because you've already had a situation where doctors waited too long and it cost you. And so we can't afford that to happen on the other side. So we do have to, take a little bit more of a proactive approach in your case. And in talking to a couple of your different vascular specialists that you've worked with that have provided you multiple opinions, is they are in agreement in your case that conservative therapy is not an option for you if you do get to a point where you are getting close to that 100% long calcified occlusion, because they need to be able to get in with less trauma and open things up for you so that you don't lose another limb. So for your situation, and especially having prosthesis on the other, you might not be able to walk as much or as briskly as other people. So they might need to be a little bit more aggressive in your case. And so in terms of questions to ask your doctor, is you do want to make sure you ask, do you think that conservative therapy is enough? Because you know that medicine and lifestyle modifications are literally number one when it comes to managing PAD, and conservative therapy is the best. If you do have a procedure, whether it's interventional or surgical, it just always starts the revolving door of treatments. And then you have to have another and another and another, which does increase the chance for another amputation, right?
Mhm.
And
Yep.
so when they do go in, I would definitely make sure that they take a less is more approach, because you don't need them to go zero to hero and cause a lot of trauma in the vessel, which is going to trigger a very quick, you're still a young guy, healing response. You just need that much more flow to maintain you, right? You just
Okay.
don't want to get to a point where it's a point of no return, where we've had situations, right, where you've ended up clotting and you have a lot of calcium in there. Then suddenly you get a clot and it just fills up the whole space, and you have an acute limb situation where we had
Mhm.
to get you to emergency very, very quickly and get you to Dr. Jafar Golzar over in the
Yeah.
Chicago area, who was
Oh,
able
you're
to
very
get
good
you
at it.
right then and there. So it's really important to have that conversation with your doctor about, what is my presentation of disease? What's the plan A? What's the plan B? What's the plan C? What are the contingency plans? Right?
Mhm.
How are we going to maintain it? You're starting with a new doctor. I want you to sit with that doctor and I want you guys to come up with a strategy. What does my care plan look like? What happens in this situation where I have an acute limb situation? How are we going to mitigate that risk for those clots? Am I on the right medications? How does my blood work look? How thin is my blood? How do my platelets, how do my, platelets look? Like, get a really good picture of what that blood work looks like and how you can mitigate the risk of clotting in your particular case. Make
Okay.
sure that he is 100% in alignment with your medicine cocktail. And I see that doctors don't spend enough time on that. And
Mhm.
you really need to, as a patient, be very proactive, because the doctors, what they're doing is they'll go to their textbook and they'll go to a recent study and they'll say, okay, you need to take aspirin and Xarelto, or you need to take Plavix and Eliquis. And they aren't paying attention to, they'll see that you're having a revolving door of treatments, but they don't think to double check at the Plavix and see if you have if it's not working for you. And sometimes Plavix doesn't work, and there's a sensitivity test that you can take. It also, sometimes Plavix doesn't work because of a certain statin you might be taking. Dr. Anita
Ah,
Dua again came out with a study on that
okay.
recently. It was a very small study, and she's expanding on it. But there is a study. It makes me just, the study was strong enough to make me question the doctor, if there is a revolving door of treatment, whether or not the medicine cocktail is correct. And despite what maybe the Voyager study says, or maybe what any of the other studies say, maybe with your presentation of disease, you might need a different cocktail. You might be an outlier. And so always, always, always have that conversation and make sure you understand why that particular combination is right for you in your presentation of disease. So for your situation, I think that that's a very important question. Number two is, I would ask him, what is his threshold for treating your leg and that blockage? What is he waiting for? What symptoms should he look for in you? Which symptoms should you look for? And at that point, based on your presentation right now in the latest CT angiogram and the look of that blockage, what are some of the options that he has to treat? Would he go straight to a surgical bypass? Would he use an endovascular approach first? In most cases, we always suggest at least trying an endovascular approach if it's safe for a patient. Do they use wires? What are their indications for using a roto-rooting device? Atherectomy. When does he use it? Which one is his go-to? And why is that particular device right for your situation? Ask him about stenting. When does he stent? What is his philosophy on stenting? Is he a less is more type of guy? Is he more of a bailout stenting type of guy, meaning that he only uses a stent if there's a long treatment area or if there's a bailout situation where there's a perforation or a dissection? Or does he just stent everything? Nice to know, right?
Mm-hmm.
And then what is his success rate with situations like yours? You want them to tell you a story about a patient just like you. And if they don't have a patient just like you might want to find a doctor. And we always say, anyway, get a second opinion before any procedure. You want a doctor that is familiar with your presentation of disease. And if they say, well, I just treat all these people, I treat everybody. Well, no, tell me then, doctor, about a patient just like me, the course of treatment that you provided for that person and the patency rate, the durability of it. And what are the chances that I am going to have a similar outcome? And then finally, what sort of risks do you see involved in these procedures that you have performed in situations like mine, if and when we decide a procedure might be necessary? And how do you, doctor, mitigate those risks during a procedure? For example, if they use an atherectomy device or, the roto-rooting device, do they place a filter below? Do they find it appropriate? Do they have access to filters that they can place below just in case a piece of plaque breaks off and goes downstream?
Right.
All of those questions are worth asking. And I wouldn't tell you, go through all of those questions with you, but I know in your case, Alan, you ask those questions. You're not afraid to ask those questions, and you do a great job asking them.
I appreciate today very, very much. It reinforced a lot of my knowledge that, do I know all this? Well, some of it was, yeah, I've got to refresh a little bit. But the doctor I found is an interventional cardiologist here locally. He has answered all the questions, and he
I'm
also has
curious,
a vascular fellowship under his belt. So he's got that
I'm
vascular. He was questioning my medicines. He's talking to my other
right.
why I was put on 20 milligrams of Xarelto. He says,
Yep.
for PAD, you must have something else going on. But he's talking to my other doctor as they pass, going back to the cath labs.
Yep.
They're both in
Because
cath
that is
lab
a
all the
lot.
time.
That is a very high dosage of Xarelto in most patients.
Yep.
And this is where I caution everyone that if you have a doctor that is only paying attention to studies and not really having an intense understanding of how the blood works and your particular presentation of disease and being willing, medicine is a practice, and it can be an art, as well.
Yep.
And so you need a doctor that has that ability to think on his feet and to take the information he or she knows and be able to adapt it to you, right? The logic behind it, the mechanism of actions behind these drugs and how the blood works and how the platelets, attach or your blood clots. It's really important for them to know this, because in your situation, your doctor did explain to me why you were on the higher dose of Xarelto. And a lot of doctors get really scared putting someone at a high dosage, because you are at greater risk of bleed. And so they don't do that for everyone. But in your case in particular, you do have to be a little bit more careful on your feet. And because you do need to have that higher dose. But I'm curious in your case, as we wrap up here, I'm curious because you did this vetting of this doctor on your own. We've worked together for a couple of years. We've talked about the questions. Would you mind sharing a couple of the questions that you asked the interventional cardiologist? Because when you came back to me, I couldn't believe the information that you were sharing about his skill set. So would you share?
Sure. One of the things I do with every doctor is first Google it. There's a lot of information, where they went to school, the fellowships they had, who did their training with them. That was done the month before this doctor actually bumped my reading my CT scan, he got early. He bumped me up a whole month to see me because of my condition is advanced or extremely advanced disease. Basically talking to him, he answered all the questions for me. He was with me almost an hour going through all the testing that I had done, that Dr. Goldzar had done up in Illinois for this last, we'll say 3-month go around with treatment. I had a few questions. Can you, I think it's retrograde, go up through the foot? Can you do this? Can you do that? One of the questions he had was my medications. That gave me an indication that he knew more about blood conditions and so forth than my vascular surgeon. And he said, I will talk to this doctor. Again, they pass between cath labs at this hospital, and I see him in 3 months, and we will find out. As you know, I like having 5 or 6 doctors for interventional, quick interventional things, since this is what happens to me. I clot overnight. Usually it's a thrombosis.
And you have bad luck with doctors right when this happens that are on a plane
Yes.
somewhere or out of the country.
Oh.
So, we never suggest,
Right.
getting to a point where you're shopping around every single time. There's something to be said for having a doctor that really knows your vasculature, has been there, done that, knows the
Right.
landscape, because everyone is really different. And a doctor that knows your landscape already has sometimes a better chance of being able to get through more complex lesions because they've been there, they've done that. They're able to go in and they don't have to start over, right? But in Alan's case, he literally. Our philosophy is I really like to make sure that you're not going into an emergency room blind and not knowing the doctor, because different doctors, different approaches, different tools. And here in the US, especially, you have a greater chance of getting your leg cut off going into an emergency room. Not to say that you shouldn't go to emergency room. You think you're having an emergency, go to the emergency room. But we always suggest on your way to the emergency room calling us, because then we can see or finding out, well, which emergency room, if you have an option, should we go to? And so Alan is sitting there on his way and he's like, which one should I go to? Where do you know a doctor that's on call that you can call and let them know to receive me? And so that's really what he does. And we do that with a lot of patients. If we know a lot of different doctors at different hospitals, we're able to say, hey, we got this patient coming in. Do you know the on-call doctor? Which person should they ask for? Is there a choice? Things like that. We can find out more for you as you head to the emergency room, so you have a greater chance of getting with someone that does have advanced skill. A lot of times in the emergency rooms, especially in a small rural community, they might not have, like the one patient I mentioned earlier in this broadcast, their vascular surgeon may be at another emergency at a different hospital, and they may not even have one on duty. And they might only have a general surgeon, and all they know is to cut off the leg. That happened to another patient of ours in Kansas, where they had a small hospital and they did not have a vascular doctor that knew how to open arteries, whether it was surgical. We didn't care if it was surgical or endovascular. We just wanted someone to follow American Heart Association and Society for Vascular Surgery guidelines to at least attempt to restore inline flow before amputation, when this patient's life was not on the line. There was time, but the only doctor on duty was the general surgeon. There was no vascular doctor literally within hours of there that could get to the hospital as his foot is turning gangrenous. So it was either just cut off the leg or cut off the leg. And so we were able, thankfully, in that case, we were able to get a hold of, he was from another state, get a hold of the doctor at his original hospital before he moved. And the doctor was kind enough and still had the ability to get him life flighted back to that hospital to try and open up those arteries. But we see it all the time. And it's by no fault of the doctor or the facility. It just sometimes is what it is. And so to be able to have a resource like ours where we can at least say, hey, maybe there's a chance we know someone, maybe there's a chance that we have someone on call. For example, in Florida, the daughter of one of our patients in Florida called me up and said on a Friday night, actually called nurse practitioner Kay when she was with us, called her and said, hey, you know what? I talked to Kym. She has this other doctor for my mom, but it's not till next week. Can you get a hold of Kym? Because my mom's foot is turning. And so I got the call. I was able to call the doctor we call Dr. Miracle now, Dr. J. Matthews in Bradenton, Florida. And he said, if you can get her first thing, I'm on call this weekend. So if you can get her 2 hours away to this other emergency room, I'm going to be the one that the doctors will call. And I will already be there ready to receive her. I will have the cath lab set up and we will at least try to open up those arteries and quick. And so sometimes, we're lucky and we have that as a possibility, but it's worth checking. And people are free to call our Leg Saver hotline at 415-320-7138. That's 415-320-7138. 415-320-7138. And talk to our PAD navigators and see how we can help. Again, we don't give medical advice. Again, we don't have any guarantees, but you know what? We will do everything in our power to fight for your legs. That is my mission. That is my purpose in life. Whatever I can do. I'm not perfect. Can I always help? No, but I will do everything in my power to try and be right there by your side and fight with you every single step of the way.
Thank you, Kym.